Hello, good afternoon.
Good afternoon.
Ayan. Sorry, naglolo ko eh. Okay, let's start. Good afternoon to all the members of Olongapo City Medical Society. Prostate cancer is one of the most common types of cancer. Some may be confined in the prostate and some may spread aggressively. And just like any cancer, early detection is the key to successful treatment. This is one of the first in the series of our cancer webinars for 2021 as part of our advocacy in cancer. And since June is Prostate Cancer Awareness Month, we hope that we'll be able to enlighten, refresh, and guide you in diagnosing and treating patients with prostate cancer. Now, may I request for our OCMS President, Dr. RJ Manso.
Prayer muna.
Yes po.
Okay.
So that we may
Mga kababayan, ang pambansang awit ng Pilipinas.
Being naka-mute ka ata.
Sorry. Yan. Now, again, good afternoon. To give our opening remarks, may I call on now our OCMS President, Dr. Joseph Manso.
Thank you, Bing. Good afternoon, everybody. Cancer has been one of the most common causes of death in the Philippines in the past decade. In 2020 alone, around 60,000 died from this dreaded disease, despite advances in diagnostics and therapeutics. It is one of the primary objectives of the current OCMS board to increase cancer awareness through this upcoming series of scientific lectures and lay fora as our information campaign against cancer. We hope to do the best we can to make the Olongapo City Medical Society advocates against cancer and our entire community as well. We now welcome you to the first in this series of our monthly lectures for doctors. Today, we welcome our dear friend, Dr. Ian Alpajaro, to supplement our knowledge on prostate cancer following our lay fora held yesterday on the same topic, care of Dr. Aris Roque. Now let us listen to experts in their respective fields and rest assured this will be time well spent for all of us. In anything in life, knowing is half the battle. A blessed weekend and a good day to you all.
Thank you, Dr. RJ Manso. Now to introduce our speaker, let me call on the Vice President of Philippine Urologic Association, Dr. Aristotle Roque.
Hi, good afternoon, everyone. I would like to thank the OCMS and the organizing committee of this webinar for giving me the opportunity to introduce our speaker. Our speaker is a fellow Tomasian, an active member of the Philippine Urological Association and the Philippine Society of Urologic Oncology. He graduated with honors in the Faculty of Medicine and Surgery, had his internship in the same institution, and of course had his residency training in the same institution, a true yellow Tomasian. He had his fellowship in urologic oncology in the University of California in 2018. He is now presently the head of the Urologic Oncology Section of Urology Department of Surgery, University of Santo Tomas, and has been an associate professor since 2019, the Department of Surgery, University of Santo Tomas. Friends, let's all welcome Dr. Siegfried Ian Alpajaro.
Hi, thank you, Dr. Roque. Of course, it's an honor to be introduced by no less than our PUA Vice President and my boss. So thank you, Dr. Roque. And let me just share my screen. Okay, nakikita niyo po ba?
Yes.
Okay.
Yes.
So, well, I'd like to thank first OCMS for this invitation. It's a pleasure to be giving this short lecture this afternoon. I couldn't say no to my friend, Dr. RJ Manso. At first, he asked me to give a lecture on prostate cancer, and then later on, he wanted me to add some discussion also on BPH. So that's why our objectives for this afternoon would be to discuss the basic science, approach to diagnosis, and updates on the treatment of number one, a short discussion on benign prostatic hyperplasia, and then we'll proceed with prostate cancer. Okay. So, So the prostate comes from the Greek word prostates, which literally means one who stands before or guardian, and it's actually hinged around the bladder neck and outlet of the seminal vesicles and the vas deferens. So it's here, right below the bladder. Its function is to secrete alkaline whitish fluid together with the seminal vesicle. So it's part of the genital system or urogenital system that provides the secretions. And its alkaline nature, the secretion which is alkaline in nature rather, neutralizes the vaginal fluids. And it also contains a lot of zinc. So it has antibacterial properties which preserves the sperm and increases their lifespan in the vagina. So just some basics, average size is 20 grams, although this becomes bigger with age. One important thing to remember, of course, in the clinic, sometimes you would see, when you get your routine ultrasound, you see 30, 40, 50 gram patients, but with no symptoms. It's because there's no direct correlation between the size and the symptoms. Okay. And then on DRE, when you do your DRE, you'll be able to feel the two lobes, the two laterals. There's also a median lobe situated here, and this cannot be palpated with your DRE. Okay. So first we proceed with benign prostatic hyperplasia. Okay. So BPH development is androgen dependent, and the testosterone is responsible essentially for both BPH and actually later on, as you will see, the prostate cancer development. And the type 2 alpha reductase enzymes transforms testosterone into dihydrotestosterone or DHT, which is the potent binder to androgen receptors. And this enzyme is actually a target for treatment. And again, we'll be discussing more on this later. The prostate is unique in that with aging, it has both an increase in epithelial and stromal cells. And there's an apparent failure of programmed cell death. So the prostate normally gets bigger with aging, and this causes bladder outlet obstruction. So this is the static cause of obstruction. And then there's also a preponderance of alpha-1 adrenergic receptors in the prostate and in the bladder neck. And so there's also a dynamic component of obstruction. So just further illustration, the increase in prostate bulk or size, that is the static component or pathophysiology of obstruction in BPH. And then there's also that dynamic component, which is caused by increased smooth muscle tone mediated by the alpha-1 adrenergic receptors, both of which can be potential targets for treatment. BPH first develops in the transition zone. So this is the transition zone. And as you can see, it's intimately related to the urethra. That's why whenever you have glandular enlargement in the prostate, in particular in the transition zone, there would be symptomatic changes in terms of the urine flow. And then the pathophysiology is mainly hyperplastic or increase in number of cells rather than hypertrophic. Although small glands may have preponderance of fibromuscular stroma, most of the BPH would have glandular proliferation. So we mentioned a while ago that there are active smooth muscles in the bladder, bladder neck, and in the prostate. And stimulation results in dynamic increase in prostatic urethral resistance. So when you see patients in your clinic, you would ask for lower urinary tract symptoms. You would ask for blood in the urine, history of UTI, urinary retention. Of course, as part of a complete history and PE, you would also take a look at comorbidities, the medications that the patient would be taking, because these would affect your treatment choices for the patient. A useful clinical tool that urologists use is the IPSS, or International Prostate Symptom Score. Although it can be cumbersome to use because the patient has to answer this questionnaire, I think it's a good guide to get sort of a baseline severity of the symptoms. And then once you start treatment, you can get another IPSS score. So you will see if there's improvement. You'll be able to assess the response to your treatment. And then, of course, detect symptom progression. The lower urinary tract symptom is composed of the following. So we use the mnemonic FUNWISE to memorize the symptoms. So F is for frequency. So you would ask your patient, madalas po ba kayong umihi? And then for urgency, yung nagmamadali na naiihi na parang hindi na napipigil. Nocturia is having to go to the bathroom to urinate at night more than 2 times. Weak stream, you can ask the patient, kumpara nung kabataan nyo, napansin nyo po ba na mas humina yung daloy ng ihi nyo? And then intermittency is paputol-putol yung pag-ihi. Straining is when the patient has to exert effort to urinate. So nag-iire ang pasyente, you can ask them that. And then incomplete voiding or emptying, it's the feeling that even after urination, there's something that's left in the bladder. So you can ask your patient, parang may naiiwan po ba na ihi kahit natapos na kayong umihi? So you can ask those questions to your patients to evaluate for the LUTs. Okay. And then part of the basic examination is the digital rectal exam. Of course, you have to palpate for the abdomen. Sometimes if the patient is in retention, you would feel that the hypogastric area is enlarged, and so that's where, and that corresponds to where the area of the bladder is. Okay, so well, everyone knows how to do a DRE, but I think a useful tool or guide is when you close your fist, when you make a fist and you feel that the prostate is like your thinner eminence, that's compatible with a benign prostate. When it's hard or it feels like a knuckle, then you would suspect for prostate cancer. If there's tenderness, then you might be looking at a case of prostatitis. So this is just a rough guide. Of course, some cancers, especially if they are situated deep in the prostatic parenchyma, you might not be able to feel it during the digital rectal exam. That's why it's very important to get a serum PSA. And later on, time and again, I'll be showing why it's important to get a PSA as a baseline for our patients. So PSA is also called HK3. It's a glycoprotein produced by prostate cells, and its function is to liquefy the semen. So although it's highly organ specific, it's not cancer specific, meaning not all prostate specific antigen elevation is equivalent to cancer right away, because there are certain benign conditions that can cause elevation of PSA. Just like, for example, prostatitis, UTI infection, even catheterization or instrumentation. Those can cause elevation, albeit transient increase only in the PSA. So its use is for screening of asymptomatic men, for staging of prostate cancer, and then also for follow-up and monitoring of prostate cancer treatment. And we'll touch on this, more on this later. Okay. The basic imaging we use for BPH, or for prostate actually, is the ultrasound. And this is actually a cystoscopic view of the prostate, showing bilobar glandular enlargement. And in, normally you would have here in the middle the urethral opening, but in this cystoscopic view, the urethra is already being blocked by the prostate enlargement. Complications of BPH would include bladder stones, recurrent UTI, hematuria, urinary retention. Of course, with chronic urinary retention that's not addressed, you can have bladder decompensation or weakening of the muscles of the bladder. You can sometimes have overflow urinary incontinence. And in more severe cases, you can have upper tract deterioration and azotemia. Medical management, we've come a long way in terms of the medicines available for BPH. The two general classes of drugs we use for BPH are, number one, your alpha adrenergic blockers. They serve to relax the smooth muscles in the prostate, thereby loosening its grip on the urethra. And then there are the 5-alpha reductase enzyme inhibitors, or 5-ARIs, as we call them, which stops the conversion of testosterone to the potent dihydrotestosterone, causing epithelial and stromal cell atrophy. Although at best, 5-ARIs can only work in 30 to 50% of patients. So for larger prostates, usually when you see prostates more than 40 grams in size, with symptoms, you can start combination therapy with an alpha blocker and 5-alpha reductase inhibitor. This is just a short list of the available alpha adrenergic blockers. The older alpha blockers would be non-selective. And then as you go down the line, we have the more selective medications. Of course, when you're more selective, the potential advantage is you have less side effects. And when we talk about side effects, mainly they're related to the blockade of vasoconstriction, causing hypotension, postural hypotension. Sometimes patients would have reflex tachycardia. Because of the improved outflow, there's also in some patients retrograde ejaculation. So actually it's fairly common for us to see patients would be happy because they have improved urinary flow, but their main concern on their follow-up is that they're not able to ejaculate. So you have to explain when you start treating them with alpha blockers that their ejaculation might be affected. And then a unique, interesting side effect of alpha blockers, although the pathophysiology is not fully understood yet, is that it can cause a phenomenon commonly seen by ophthalmologists called intraoperative floppy iris syndrome. Particularly in tamsulosin, and I think silodosin because they're very selective. So when you're using tamsulosin, you have to coordinate, talk to your ophthalmologist because you might need to adjust or stop temporarily the alpha blockers if they're doing certain procedures. And then the next class of drugs, the 5-alpha reductase inhibitors. As I said a while ago, it blocks the conversion of testosterone to dihydrotestosterone. And so potentially it can help shrink the size of the prostate. There are two popular 5-ARIs available. One is finasteride, and then the newer one is dutasteride. More or less, they are equal in efficacy. An important reminder, I think, if I have to say something about this class of medications, is that this affects your PSA value. And after 6 to 12 months of treatment, the PSA is expected to decrease by 50%. So make sure you get a baseline PSA before using 5-ARIs, because if you don't take note of the baseline, you might be getting falsely low PSA levels when trying to screen for prostate cancer. For example, if the patient has already been on finasteride, for example, for a year already, and then you get a PSA, and then you get a result of 3, you have to multiply it by 2 So that's actually a 6. So meaning mataas na yung PSA, meaning indicated na mag-work up ka for prostate cancer because the PSA is already elevated. So make sure you adjust and interpret your PSA values accordingly based on the use of certain medications like your 5-ARIs, so that you don't misdiagnose or underdiagnose the potential presence of cancer. And then of course, very common sa clinic, magtatanong ang mga pasyente yung mga certain mga non-FDA approved na gamot, like the ones here. Basically, there's not enough evidence. So I would tell the patients that probably they can help, but there's no proof yet. So it's just potentially additional cost, I would tell them, but probably it won't harm if they use it. So it's up to them if they want to use it. That's what I tell them. Pero dagdag gastos. So I would suggest to them that instead of spending their money on yung mga alternative treatment, just focus on the scientifically proven medications like your 5-ARIs and alpha blockers. Of course, not all cases of BPH would respond to medical treatment, and some will require surgical intervention. So once we see the absolute indications for surgical interventions, then we offer surgery. And these are upper tract deterioration, recurrent UTIs, refractory urinary retention, bladder stone formation, and recurrent gross hematuria. So whenever we see at least one of these 5 things in a patient, then it means that medical treatment is no longer effective, and we would offer surgery. Of course, relative indications for surgery would be patient preference. If the patient no longer wants to take medications and once and for all address the symptoms, and then if they have bothersome LUTs despite being on the medications religiously. Okay. So for surgical management, we have prostatectomy, but now we rarely do open prostatectomy. We utilize minimally invasive techniques now, in particular TURP, which remains the gold standard treatment for BPH. So let me just show you a video. Probably everyone is already familiar. Maybe when you were in medical school or when you were assisting during residency. So during TURP, we have an instrument called a resectoscope, and at the tip of the resectoscope, there's a cutting loop, which is electrosurgical. It's connected to electricity. So we insert the cystoscope, resectoscope into the urethra, and then once we reach the prostate, we identify the part of the prostate that needs to be resected. So the margins or the landmarks we use would be the bladder neck. Proximally, distally would be the veromontanum, and then we don't violate the capsule of the prostate. Then, of course, after TURP, we would place a Foley catheter with irrigation usually until we get a clear backflow. So usually around 1 to 2 days with the catheter. So in summary, BPH remains to be a common problem in the old men. There's improvement in available medical treatment, which delays and even prevents need for surgical intervention. And it's important to screen and rule out prostate cancer first before treating a patient as a case of BPH. So you use your PSA, your DRE to make sure that you're treating a benign prostate. Now we proceed with the second part of our discussion, which is on prostate cancer. In the US, it's the most commonly diagnosed cancer in men and the third leading cause of cancer-related death in males, and worldwide is the fifth leading cause of cancer-related death in males. Prostate cancer is a disease of older men. It's rare in men less than 50 years in age. But with the use of PSA, we noticed that we're able to detect or diagnose patients at a younger age. And this shift in diagnosis to an increasingly younger population is attributed, as I've said, to PSA screening. And because of PSA screening too, it's been observed that there's a shift to a more favorable stage at diagnosis. Rather than catching patients late, like for example, stage 4 metastatic, we are able to catch patients earlier at a curable stage. So risk factors, genetics and environment. If you have a father who has a prostate cancer, you have twice the relative risk. If you have a brother affected, you have 3 times. If you have 2 first-degree relatives, you have 5 times relative risk. So you have to be more aggressive also in screening patients if they have family history of prostate cancer. Genetics probably not used as much here yet, but you might, the most popular actor would be Angelina Jolie, who had the BRCA mutation. BRCA-associated cancers, and for prostate cancers, they are associated with higher grade locally advanced metastatic disease and worse cancer-specific metastasis-free survival after prostatectomy. So in the States and in Europe, they would usually screen for these genes even at the time of diagnosis of prostate cancer, so that if they are positive for BRCA, they would be more aggressive in their management. Here in the Philippines, not sure. I think we still have to send out our specimen to Singapore if you're interested in doing. Or maybe I think it might be available in St. Luke's, I'm not sure, but at a steep price. So it's not routinely done yet in the Philippines. So other risk factors, inflammation, infection. Currently, no specific infectious agent has been identified. The use of testosterone supplements association has been inconsistent. Vasectomy, I think that's already been settled, no increased risk. Cigarette smoke, just like with other cancers, always a risk factor naman. And then, interestingly, from Harvard, they found out that men who ejaculated 21 times a month had lower risk of prostate cancer. So this is something to think about for men, and para dun sa mga wife din na gustong tumulong dun sa mga husband nila. So tulungan nyo siguro maka 21 times a month, no, to lower the risk of prostate cancer. Diet. It seems that dietary fat intake might be associated. They're reporting from Australia because they have a lot of baka, no? They love steak in Australia, and in terms of incidence, they have among the highest worldwide. And Western diet too, which is very high in fat, meat intake, they have higher incidence compared to Asians. Okay, obesity seems to be seems to have a modestly increased correlation with prostate cancer. And then, of course, yung androgen, sila rin yung responsible, particularly dihydrotestosterone. That's why later on during this discussion, again, the androgens would be the target for treatment for prostate cancer. So how about chemoprevention? Is there something we could take to prevent prostate cancer? And in fact, patients would ask us, may pwede bang inumin, may vitamins ba na pwede akong i-take, doc, para ma-prevent ko na magka-prostate cancer? The answer is, wala talaga, okay? One study used finasteride to see if it can prevent prostate cancer. Turned out to be a negative study. Another study, the PCPT trial, in that study, they use calcium and selenium, I think, supplements to prevent prostate cancer, pero after a long follow-up study, there was no benefit. So basically for chemo prevention, wala pa. Okay, there's none yet. So since PSA is very important, let me again discuss this. I think I mentioned this a while ago. PSA is not cancer specific, but there's a substantial overlap in PSA values between men with benign versus malignant prostate cancer. And so anytime you have inflammation, even BPH, you can have high PSA pa din, not just cancer. The basic pathophysiology why there's increasing PSA is when there is disruption or alteration in the tissue architecture of the prostate. So meaning, hindi lang cancer, pati inflammation, pati trauma can cause those PSA elevations. So ito, the loss of barrier afforded by the basal layer and basement membranes within the normal gland is a likely site for egress of PSA into circulation. So on a per cell basis, PSA expression is similar between benign and malignant. But again, the disruption of cellular architecture within the prostate gland leads to the egress of the PSA nga into the blood circulation. So when you get the PSA from the blood, there's PSA elevation, for example, in prostate cancer. So PSA and percent chance of prostate cancer. So this table clearly shows that PSA is far from perfect. As you can see, even for men with PSA more than 10, 67% lang yung chance ng cancer. So wag kayong magpapanik. Even with the high PSA, it can still be a benign prostate. But it just means that you have to investigate further. And when I say investigate further, that means to get biopsy or at least an MRI. I'll show the data in the following slides. Other ways to improve the use of PSA is to adjust or compute for the PSA density, which is computed by using the PSA value in relation to the volume of the prostate. So if it's more than 0.15, then you would be more suspicious of a malignancy. And then you can also use a free PSA. It's available in some labs. If more than 25% yung free PSA, then you would be more suspicious of cancer, meaning you have to investigate further. And these two parameters, itong PSA density and free PSA, they're especially useful if your PSA is between 4 to 10. This PSA value between 4 to 10 is what we call the gray area or gray zone in PSA. Because as you can see, between 4 to 10, 25% lang naman yung cancer. So meaning 75% won't have cancer and won't actually need to have biopsy kung iisipin. That's why you can use this. Okay, but there are better techniques being developed now na mas accurate pa sa mga ito. Lalo na pag yung PSA is between 4 to 10. So I'll show them later. In terms of symptoms, early stage prostate cancer can be asymptomatic or may mimic the symptoms of BPH. It's not until it's already advanced or metastatic na nagkakaroon ng bone pains, symptoms of cord compression, azotemia. When you see these symptoms, usually advanced na yan. So mukhang BPH lang kadalasan ang early stage prostate cancer in terms of symptoms. Of course, when you do DRE, there can be induration or nodularity. But again, what if yung cancer is naandito or naandito, hindi nakakapayan ang DRE, di ba? So that's why in addition to DRE, you have to use your PSA. Okay. In terms of pathology, 95% of prostate cancers are adenocarcinomas. The other 5% are relatively rare. And several cancer imaging studies we use for prostate cancer, the classic would be ultrasound, in particular transrectal ultrasound of the prostate. And we use this for biopsy, for follow-up, even for treatment, like when we do brachytherapy. So ultrasound is very useful. the classic appearance of prostate cancer on ultrasound is that of a hypoechoic lesion in the peripheral zone, because 70% of prostate cancers would arise in the peripheral zone dito sa area na to. But the lack of distinct hypoechoic focus does not preclude proceeding with the biopsy, because 39% of cancers are isoechoic and 1% may even be hyperechoic. So, kung iisipin, 60% lang yung kayang makita ng ultrasound na cancer na mukhang hypoechoic. The other 40% potentially can be missed by ultrasound. Okay? So how do we improve screening? So we want to increase the accuracy of the biopsy. We want to avoid unnecessary biopsies too. Now, dito na papasok ngayon yung role ng MRI. And I think for the last 5 years or so, there's been an increasing role for the MRI for prostate cancer detection. And not just detection, but also potentially avoiding recommending unnecessary biopsies. Okay. So for prostate MRI, we use 3 sequences, the DWI, the T2W, DCE. Although pang radiologist ito, but these are the components used for MRI. When we request for an MRI of the prostate, the radiologist would even make an illustration of where specifically the area of suspicion is. And when we see this, for example, here, then we would be more aggressive in targeting this area and not just sampling the whole prostate. So there's a scoring system called the PIRADS system. Di ba sa breast may BIRADS? The prostate has PIRADS. So ito yung corresponding na grades. So if we see a PIRADS 1 or 2, there's no need for biopsy actually. It's been proven by several series already. 3, based from literature, 30 to 50% chance of cancer. So still consider doing a biopsy if you see a PIRADS 3. If it's a 4 or a 5, definitely recommend a biopsy. If it's PIRADS 4, the probability of cancer when you do a biopsy is around 70%. If it's a 5, 90% or even higher probability. So, well, this is just a table showing the available data we have. So yeah, prostate biopsy, recommend when you have elevated PSA more than 4, abnormal D or E, or a combination of 2. Again, it's traditionally done with ultrasound alone, no? Yung ultrasound guidance, transrectal, but there's a new technology called the fusion biopsy, which utilizes MRI and ultrasound. So when we do this, we first get an MRI, and then the MRI data, we load it to the fusion biopsy machine. And then, as the term implies, the MRI images is fused with the ultrasound picture or image. And this is actually it's already a fused image. Ultrasound ito. And then the MRI detected a lesion here. So in real time, when we get a biopsy, ganito yung nakikita namin when we do a fusion biopsy. So it's a targeted biopsy. We are not doing biopsies blindly anymore. The classic biopsy is the 12-core biopsy na nagkukuha ng sample na parang ganito na tagdadalawa sa left and right, base, mid, and apex. Now, kasi what if, for example, this, paano kung yung cancer nandito o hindi siya tinamaan? Now, with the MRI ultrasound fusion biopsy, hindi tayo blindly nagbabiopsy na. Of course, I think the main drawback would be the cost, no? So you have to get an MRI, and then the fusion machine, the fusion biopsy machine. I think Dr. Roque will correct me if I'm wrong, but I think only 3 hospitals right now in the Philippines would have this, no? So St. Luke's Urology Center and then Chinese General. Probably may bago ng ibang meron, pero sa Philippines currently, I think, yun lang yung meron. Of course, other hospitals would be getting this fusion biopsy machine because this is becoming the standard now abroad. So later on, we would have more machines available. But this is the standard now, if you'll ask me. Compared to compared to the pure ultrasound guided biopsy, we had a local study when I was a resident. The accuracy of this ultrasound alone biopsy was only 40, at best 50%. The fusion biopsy, the accuracy was over 90%, and that's compatible with international data. So it's such a big difference that I think our patient deserves to be educated before they would decide. No, you have to tell them, educate them that ito yung mga available so that they'd be potentially getting the best possible diagnosis and treatment. Okay. So talking about complications, the most common would be infection, bleeding, urinary retention, and others. Although, with the transperineal approach, kasi transrectal ito eh. This is the classic transrectal approach we do. But ito na naman yung isa pang bago. Instead of doing a transrectal, we do transperineal biopsy. So hindi na tayo dadaan sa rectum. Alam niyo naman ang rectum is full of bacteria. The main problem is the potential for sepsis. You can do away with sepsis, very low risk if you do transperineal. No? So ito yung isa pang parang modification. Aside from the fusion, you can offer the transperineal approach biopsy. So current best approach for biopsy in terms of improved detection, accuracy, and lower complication rate would be the MRI ultrasound fusion biopsy via transperineal approach. So yan yung based on evidence. Ito yung available na, or ito yung best kung if given the ideal setting, you know, if we would take out the economic cost side of things, ito yung best na pwede natin i-offer sa patients. Okay. Then once you already diagnosed or detected cancer, then part of the workup would be to stage, and the bone scan is part of staging. So if it's positive sa bone, then that's already stage 4. The treatment would be very much different if it's a negative bone scan. Since stage 1 to 3 pa lang, pag negative yung bone scan, you would still aim for cure. Pag stage 4, then you would just want to sort of slow down the disease spread. So ang favorite puntahan ng prostate cancer is the axial skeleton, in particular the lumbar spine. Okay. Other emerging bone imaging tests would include PSMA PET. Not readily available sa lahat-lahat pa, pero in the next 5 to 10 years, I think dadami na yung PSMA PET. Okay. So so ito siguro pag nakakakita kayo ng mga pathology report, may mga Gleason score kayo nakikita, and then nag-evolve na rin ang pagbabasa ng pathologist. Originally, it was just the Gleason score, which is the sum total of the two most common patterns seen under the microscope. Now, grade grouping na ang ginagawa. So the old Gleason 6 is called grade group 1 na. Yung 7, they divided it to 2. If it's a 3+4, it's grade group 2. If it's 4+3, it's grade group 3. Because 4+3 is more aggressive than a 3+4. And then when you get an 8, 9, or 10, those are high-risk prostate cancers. So these would be the more aggressive types of prostate cancer, yung mga grade group 4 or 5, or yun nga, Gleason 8, 9, or 10. Okay. Staging, hindi na natin gaanong ano. Okay. The optimal form of therapy for all stages of prostate cancer, especially for stage 1 to 3, remains a subject of great debate. And ito, pinapakita ko lang to. This is a very busy slide. But the treatment of prostate cancer begins with proper risk stratification, meaning you have to classify the patients sa groupings na ito. Dito sa mga risk groups na ito, dito madedetermine kung ano yung, based on evidence, best na may offer mo for patients. So this is based from the NCCN and other guidelines. For very low or low, you can even offer watchful waiting or active surveillance, meaning you don't give any active treatment right away, but wait until there's progression, saka ka lang mag-intervene. Of course, you can offer prostatectomy or RT. When you have intermediate risk disease, then you have to treat it more actively. Radical prostatectomy and RT, they are equal in terms of efficacy. For high and very high, RT and radical prostatectomy would be options. Of course, there's still an ongoing debate in terms of sino mas magaling for high and very high, RT ba or radical prostatectomy, but you can offer either. Others, cryosurgery, focal therapy, currently low-level evidence, so hindi ko pa siya nire-recommend din, personally. Okay. So watchful waiting, active surveillance, we reserve that for low-grade, Gleason 6, for example, low-volume cancer. When you're on this treatment protocol, you have to follow up regularly with every 6 months na PSA, DRE. So when there's a PSA rise or progression on DRE, you have to repeat a biopsy. Pag hindi nag-Gleason 6 or dumami yung course ng cancer, pag nag-repeat ka ng biopsy, then you have to proceed to either prostatectomy or radiation. Of course, this is also for patients who are unfit for surgery. Okay. So radical prostatectomy, the classic approach, we still do a lot of these, would be the open radical prostatectomy. It's usually a bloody procedure, 4 hours, 5 hours, sometimes 6 hours. So, meron na ring available either lap or robot-assisted laparoscopic radical prostatectomy. So just to show you, this was actually me when I was doing my fellowship. So instead of yung, because remember the prostate is in a very deep in the pelvis. So you never see this operative field. Hindi ganito yung itsura pag open. Malalim na malalim yun. May element ng lock ng konti and hula, I would say, when you do open surgery. With the robotic or kite lap, actually, you have this view. So to orient you, this is the prostate here. This is the bladder. So this part, we're already trying to separate the prostate from the bladder. As you can see, normally the prostatectomy is a very bloody procedure. On the average, 1 liter or more yung blood loss. Here, you can see that because of the pneumoperitoneum being used, halos walang blood loss kasi natatamponad nung ano. Plus the superior visualization, you're able to see all the blood vessels. So you're able to coagulate all bleeding vessels or bleeders. So the problem is, I think there are only 3 robot machines pa lang in the Philippines. PGH, St. Luke's, and Medical City. But even if they're available, very expensive. So compared to open prostatectomy, in terms of cost, at least 3 to 4 times yung difference ng cost. That's why hindi pa nag-a-advance gaano yung use ng robotics sa atin. Mainly because of the unavailability of the machines and the economic reason. And then next would be radiation, which can either be in the form of brachytherapy or EBRT. So primarily, ang ginagamit talaga is EBRT. Yung brachytherapy reserved siya for yung mga less aggressive, low-risk prostate cancer lang. So I won't really go into details, pero ito yung mga available na treatment for prostate cancer using radiation. So how about for metastatic disease? Basically, what you do is castration, either surgical, which is to take out the source of the testosterone, yung mga testis tatanggalin, or androgen deprivation therapy, okay, ADT. And ADT is the backbone of treatment for metastatic prostate cancer. The current trend is to combine your ADT with your novel hormonal therapy or chemotherapy. So itong apalutamide, abiraterone, enzalutamide. Docetaxel, of course, everyone knows that this is a cytotoxic chemotherapeutic agent. So ang problema dito sa mga as you can see, it's already category 1, meaning ito yung preferred treatment in the ideal setting. But the problem with these medications, per month nasa 100,000 ata itong mga to. And this is lifelong, okay, until mag-progress yung cancer. So you're looking at easily additional 1 million per year additional cost if you give these treatments to your patients. So not everyone, probably less than 1% of the population sa Pilipinas would be able to afford yung mga novel hormonal treatment na ito. So most of our patients, pure ADT lang, may mangilan-ngilan nakakakaya nito. But ang hindi pwedeng mawala for treatment of metastatic prostate cancer is yung ADT. Or kung hindi kaya ng ADT, orchiectomy. Okay. So despite, giving the proper agents, eventually magpo-progress into castration-resistant prostate cancer. The definition of castration-resistant prostate cancer is rising PSA or progression despite castrate level serum testosterone. So this means binibigay mo yung ADT, binibigay mo yung mga gamot, pero pataas pa rin ng pataas yung PSA. And this is because after 3, sometimes 5 years of treatment of prostate cancer, the cancer is able to evade your treatment and able to find other sources of stimulation or androgen. Kahit na pinababa mo na yung androgen or testosterone, nakakahanap sila ng ibang parang trigger or androgen nga or androgen source para mag-proliferate. So pag dumating ka na sa stage na to, actually once you hit castrate resistant, ito na yung medyo terminal. This is where all the morbidity and mortality actually of prostate cancer happens. That's why ito yung trend, because it's been seen that when you use the combination treatments, you delay the appearance of castrate resistance by 1 to 2 years based from studies. Kasi nga, when you become castrate resistant, that's the terminal terminal parang phase or part na ng prostate cancer. So if you can delay the appearance of a castrate-resistant disease, then you'd be doing a lot for your prostate cancer patients. So, well, we would offer these to our patients with castrate-resistant. But pagdating sa point na to, it becomes very difficult. And we usually work, of course, with the medical oncologist when we see these patients. Okay. So in summary, PSA screening is very important. All men over 50, you should get a PSA DRE. If they have family history, start earlier at 40. If possible, use available technology like MRI and more advanced biopsy techniques to improve detection. For localized prostate cancer, we have several options for treatment: active surveillance, radical prostatectomy, radiation. The decision or choice would be, of course, based on a shared or mutual decision between you and the patient. For metastatic prostate cancer, the trend is to start strong with combination treatment to delay the progression to castrate-resistant prostate cancer. So that's my last slide. Thank you. I think we'll proceed with the Q&A.
Thank you, Dr. Alpajaro, for that very detailed lecture. Let's give Dr. Alpajaro a virtual round of applause. Now, I'm glad that I was able to listen to your lecture, Dr. Ian, kahit wala akong prostate. Pero this will be of use to my patients, of course. Now, I'll be able to do rectal examination to all my male patients din. Swerte nila, no? But anyway, just kidding. Now we are formally opening now the floor for any questions. If you do have any questions or clarifications, you may unmute your device or raise the hand icon or type in your questions in the chat box. But before I call on you, let me take this opportunity to ask Dr. Alpajaro. Sir, we know that you've mentioned a while ago. Now, we know that prostate change as men age and cause problems in passing of urine. Now, just to give emphasis on the symptoms of prostate cancer, how will you now differentiate BPH and prostatitis from prostate cancer? Can you differentiate them by symptoms alone?
So sometimes it would be difficult. I think the important differentiating factor would be when there would be sort of symptoms of infection, like there would be sometimes, or more, it's common for patients with prostatitis, for example, to have fever. They would have more acute onset of symptoms also, rather than yung sa BPH kasi more slow and progressive. On rectal exam,
Yes.
exquisitely tender yung DRE, masakit for the patient. And in fact, if you're suspecting for DRE, for prostatitis, wag mo nang i-massage yung prostate because you might end up with sepsis sa patient. So, well, those are just some other symptoms not commonly seen in BPH would be yung vague na parang perineal pain. Some patients with prostatitis would have that. Pag nakaupo, parang may something sa perineal area, they would report that. So it's actually a clinical, clinical sort of assessment, no? And suspicion. There should be a level of suspicion for that.
Okay, sir, thank you. Dr. Arturo Mendoza is raising his hand. Sir, you may unmute your device. Dr. Mendoza? Yes, sir. Sir? Before I call on Dr. Mendoza, we have here a question from Dr. Carl Ediher. According to Dr. Carl, he is asking, is it true that prostatic massages, the ones you get in spas, could really help you prevent prostate CA? This was for a friend daw.
So, there's well, the best answer I would be able to give that would be the correlational study from Harvard.
Yes, you've mentioned it.
So I have to go there 21 times, Doc. Hindi naman.
Yes, or more.
Or more.
Walang Carl, there's no parang solid evidence pa on that.
Pero kasi I've heard of that marketing kasi. It prevents them. So I know someone na parang may pari pa daw siyang even priest daw go to that that therapist because of that study daw. So yeah, okay. So we'll bank on the 21 times na lang, not on a third person doing that for them.
Good luck, Carl.
Thank you, Doc. Thank you, Doc.
Pero Dr. Alpajaro, di ba it depends on the age? Sabi nila, if the patient is younger, if you do masturbation, that increases the risk for prostate cancer. Unlike for male who masturbates frequently, let's say at the age of 50. So, meron bang difference between the age regarding ejaculation?
Well, the problem kasi with yung mga studies like, yun na yung sa Harvard na nga na study na yun is parang, parang correlation study lang yun. It's not even experimental, di ba? So, parang more observational na mga na mga data.
Yes.
That's why it's hard to parang give recommendations based on yung mga ganong klaseng information.
O sige, doon na lang tayo sa Harvard. Matutuwa pa sila.
Kaya diba?
Carl, tawagan na lang kita mamaya.
We have another question from Dr. Shella Fernando. She is asking regarding supplements like the Quinkal. That it has benefits on BPE. If yes, can we use it with known drugs for BPE? Are you familiar with Quinkal?
Quinkal. Well, not so much actually, but in general, at least for urologists, no, yung mga supplements, hindi siya part ng mga recommendation namin. And usually, yung mga supplement, if you read their containers, may nakasulat no FDA approval or no approved therapeutic claim. So I think that says a lot about their efficacy. Or at least siguro, hindi pa napuprove. Eventually, baka ma-prove. Pero right now, unless na may literature na available, we won't recommend it. So parang pag may nagtatanong, sinasabi na lang namin sa pasyente, parang vitamins lang siya. We don't guarantee na may maitutulong siya. Pero you can take it if you want. So parang hinahayaan ko na lang yung patient na mag-decide kung gusto nila yun. Pero I would remind them na pwede mong inumin yan, pwedeng hindi. Basta yung binigay ko na alpha blocker or 5-ARI, inumin. Kasi yun yung may scientific evidence. Yun yung sinasabi ko.
Yes, thank you, Doctor. Another one from Dr. Dave Calapatia. He is asking, will testosterone replacement treatment increase incidence of prostatic hypertrophy or CA?
This is actually a very controversial topic. The most recent available data would suggest that there's no actual direct increased risk in development, particularly of prostate cancer. But if you're already diagnosed with prostate cancer, then that's when you should be more careful in taking those testosterone supplementation.
Yes, thank you, thank you. Do you have any other questions to Dr. Alpajaro? You can type in or either unmute. Parang shy pa sila, sir.
Si Carl daw, tatawag na lang sa akin. Nag-text siya.
So regarding the PSA test, so usually me as an internist or probably some of our family medicine or general practitioners, no, regarding the request for PSA, the total zero PSA, yun lang lagi natin nire-request eh. Regarding that, meron po ako nakita o nabasa regarding the free PSA test. Can you tell the difference between the total PSA from free PSA and when to use it?
Yung free PSA actually it's not readily available. Most of the labs would have yung total PSA. Yung free PSA, it's very useful if you have a PSA result na total of between 4 to 10. Kasi nga, it's the gray area or gray zone for prostate cancer.
Yes.
Based from studies, you have, if your free PSA is 25% or higher, you would be more suspicious of prostate cancer. So then you would proceed to yung parang algorithm na papunta sa pag-diagnose or pag-investigate ng kung meron bang prostate cancer.
Yeah.
But napapalitan na kasi, kunyari, itong PSA kasi, more of screening na lang siya. More and more, napapalitan na ng other diagnostic modalities like MRI, for example.
Yes, sir.
Yung investigation. So parang, kasi mas marami kang data na makukuha with an MRI. And you can even triage patients if they need a biopsy or not based from the MRI, kahit na mataas yung PSA nila.
Yes. Tama. Thank you. Now, we're talking about ano, sir?
Medyo mahal
Yes,
nga lang. Pero, alam mo yun, you have to explain to the patient the benefits kasi.
To avoid also the
biopsies,
yes, and the accuracy of the biopsy. Opo. And now, sir, we're talking about the PSA total and the serum and the free. How about the urine PSA? What can you comment about the urine PSA? Is it available here in the Philippines?
Urine PSA.
Opo.
Not very familiar. Even when I had my fellowship abroad, we were not using it. So probably I'm not in a very good position to comment on that.
Okay, thank you. Do you have any other questions to Dr. Alpajaro? Can we
The clarification, di ba the MRI is just, hindi siya regular na MRI? I think
Alam
there's,
ko, Kyle, kung ano naman yung tatanong.
hindi na. Naka-move on na ako, bro.
So the MRI
Yeah, the request is, may tawag dun sa MRI.
multi-parametric prostate
There you go.
MRI.
Multi-parametric.
Yes, so it ideally it's contrast enhanced, but nag-evolve pa ito. Kasi yung tawag sa MRI multi-parametric. In Europe, they're studying now yung tinatawag na biparametric MRI, which takes away the need for contrast. So they're trying to compare now, large study ito, multi-parametric versus biparametric. Currently, it seems that mukhang comparable. So in the future, hindi na kailangan ng contrast kasi not all patients are able to have contrast pag mataas yung creatinine, for example. You expose them to risk of renal failure. So this is still evolving. Okay.
Noted, Doc. So regarding, my dad's case, diba? So I think the next, let's talk about it in a different time. He's a PSA din, Dad.
Yeah.
Okay. Thank you, Doc. Thank you.
MRI.
Yes, Doc. Yun nga po.
Thank you, Doc Carl. Another question from Dra Ursula. For grade 2 prostatic CA, what management would you recommend for persistent dysuria currently on indwelling catheter? So I think that's a good question too.
So I just have to clarify ito, Doktora. Stage 2 po ba na prostate cancer or grade 2 na prostate enlargement po ba ito? Kasi grade group 2 prostate cancer po ba, Doktora, ito? Or
Dra Ursula?
clarify lang po.
Opo. Is it grade 2? You may open or unmute, Doktora.
It's grade 2, prostate CA.
Irrespective of the pre-operative
Parang Gleason 7 prostate cancer, ganun po ba, Doktora? So I assume
the role of pre-operative
metastatic prostate cancer na
done by chef and police and
parang ito.
shown.
Actually, yun ang diagnosis sa kanya eh. Grade 2 prostatic CA with no bone mets.
Well, kasi Doktora, if it's non-metastatic prostate cancer, and especially if the patient is otherwise healthy, then you can address the dysuria and the obstruction or the need for an indwelling catheter via prostatectomy. So aside from addressing the cancer problem, you will also be able to address the obstruction problem.
Okay. He's relatively healthy and he's considering it.
Kasi the catheter itself is very irritating and can cause yung dysuria or bladder pains.
Okay. Thank you, Ian. Thank you.
You can give certain medications in the meantime, like for example, yung mga antispasmodics or mirabegron, for example, vesicare, solifenacin, no? Para lang mabawasan yung bladder irritability habang naka-catheter siya in the meantime.
Okay. Thank you, Ian. Thank you.
Thank you, Doktora. Now,
Thank you.
another question from Dr. Armin Mendoza. What is the prognosis of prostate cancer patients diagnosed early and given the appropriate treatment?
The prognosis will be very good. Like what I said, early diagnosis, early treatment, you would be shooting for cure. Versus when you catch a patient stage 4, for example, then you would just be doing palliative treatment. So curative intent tayo kapag early stage. Localized prostate cancer specifically.
Yes, thank you. Now, another question from Dr. Dennis Delgado. Can patients with prostatic CA undergoing treatment have sex? Are there any precaution to observe?
Well, depends which treatment. For example, some patients who had radical prostatectomy can still have erection, although they will not have ejaculation anymore. Some patients undergoing hormonal therapy, even if they want to have sex, they don't have the libido anymore kasi pinapababa mo yung testosterone level. But sure, prostate cancer is not a contraindication for sex. No. In terms of precaution, wala naman, the usual.
Is it not painful for them if they do or have intercourse?
Yung may prostate cancer po.
Yes, sir.
Wala naman po ano. Oh, by the way, yun lang. If they're taking, by the way, yung mga certain drugs like yung mga hormonal treatment, if you'll see yung mga sa mga package inserts ng mga ano na yun, gamot, you should use protection kasi nga hindi pa na pag-aaralan or can cause parang yung sa abnormality, yung sa pagbubuntes would cause abnormalities, no? So use protection if you're using your hormonal treatment. Yun lang. Kasi na pag makabuntis ka, baka mag-cause ng defects sa bata.
I see. Talaga.
So yun lang.
Okay. Thank you, sir. Hello from Dra Briones. For an 80-year-old male who, for example, was found to have non-metastatic prostate CA on MRI fusion biopsy, I think she's asking the management.
Well, I always tell my patient, age is just a number. Meron kang makikitang 90 years old na nagmamarathon. Meron kang makikita na 50 years old pero naka-wheelchair na. So 82 is just a number. I mean, if it's relatively strong still, good candidate for surgery, I would offer prostatectomy or equal naman sa surgery ang outcomes ng radiation. If there are no contraindications, I would offer radiation. Kasi pareho namang curative ang radiation at saka prostatectomy for non-metastatic prostate cancer. So,
okay.
This would be my options.
Will that the survival, doctor?
Curative pa rin yung intent natin for both.
Okay po. So, do you have any more questions? Wonderful lecture daw, Doc.
Thank you.
Now regarding, sir, the enlargement ng prostate. So, just to reiterate, is an enlarged prostate a precursor to prostate cancer?
No. In fact, you can see men with prostate cancer na less than 20 grams yung size ng prostate. So the prostate enlargement is basically inevitable. Lahat ng lalaki would have, at some point in their lives, would have some degree of prostate enlargement. The question is, would it cause enough symptoms to cause obstruction or blockage of urine? And of course, you have to screen for the development of prostate cancer.
Yeah. Thank you. Dr. RJ Manso is asking, not a pre-malignant condition. What about this, sir?
Yung prostate enlargement?
Probably yes.
Corollary to the comment. So it's never a pre-malignant.
150 gram prostate, 200 grams benign naman. Versus a very small prostate that can be harboring malignancy. So size itself, not correlated with the presence of cancer and also not directly associated with or not directly correlated in terms of severity of symptoms.
Even in long-standing ng BPH, wala siyang pre-malignant or malignant transformation. Yeah.
Pero you have to be doing your annual screening, PSA-DR.
Okay. Thank you.
Thank you, sir. Now, Dr. Acosta is raising his hand. Yes, sir, go ahead.
Hello?
Good afternoon.
Yung anak niya yata yung magtatanong.
Yes, sir.
Jerome,
Mute ka, Jerome.
Oh, sorry. Ingat niya. Ingat ng mga kids ko eh. Guys. Right. So with regards to the screening, Dr. Ian, at what age or which circumstances would you recommend early screening, since you said a little while ago that an enlarged prostate does not necessarily mean a prostate malignancy. So like, for example, I have a strong family history of cancer. Do you recommend me to undergo like kahit PSA, not really the MRIs muna for any screening of malignancies?
Well, if you have family history of prostate cancer, you want to start screening earlier. The recommendation would be as early as 40. Now, if you will allow me to share my screen again, pa-share ko lang ulit yung screen ko ha. Ipapakita ko lang itong so ito, age-adjusted PSA. Nakikita niyo ito, Jerome?
Yes, Doc.
So, for younger patients, the cutoff for PSA is lower. So you adjust. So if you're between 40 to 49, pag ikaw 2.6, mataas ka na. Parang ganun. So just take note no na. Pero for those with family history, as early as 40, you can start screening na for with the PSA. And then use the following age-adjusted.
Screenshot ko na lang, Doc. Thank you.
O kaya send ko sa iyo mamaya.
Papa-DRE na lang daw ako if ever.
Okay. Gusto mo kaliwat kanan pa? Pwede.
Ay, wag ganyan, sir.
Teleconsult na.
Nandiyan naman si Doc Din.
Ay, wag. Pag galit siya sa akin, yung dinidre niya ako. Thank you, Doc. Very informative.
Thank you.
Do you have any more questions to all our members? Let's go back. Kung nandiyan pa po Dr. Arturo Mendoza, kanina he's raising his hand. Sir? Puro praises na to, sir. A great lecture.
Salamat po.
Okay, if you don't have any more questions, wala na po ba? Marami pang oras. Pero if you don't have any questions, we would like to thank Dr. Alpajaro. Wonderful, great lecture po. Okay din po ang mga sagot. Satisfied naman po kaming lahat. Now, may we call on now our OCMS President, Dr. RJ Manso, for the Certificate of Appreciation.
Thank you.
Yes, sir.
And congratulations, Ian, for a very, very informative lecture. Interesado lahat, lalo yung mga lalaki.
Carl lang, sobrang mamaya tatawagan ko na lang si Carl.
Okay.
2 hours, ha? So anyways,
and there's may
like
humabol,
to...
Doc.
Doc,
May
may
humabol,
humabol, sorry.
Sige, go.
Opo, from Dr. Espinosa, would HPV vaccination be strongly recommended to prevent prostate cancer?
Well, Doctora, currently there's no specific infectious agent that's directly correlated with the occurrence or development of prostate cancer. I am pro HPV vaccination even for men because it would prevent, of course, yung warts and yung development of penile cancer. But in terms of yung benefit niya for prostate cancer, not very clear right now. Well, pinag-aaralan pa naman ito, but in terms of prostate cancer, yung benefit lang ng HPV vaccination remains unclear. But sure, for the purpose of the prevention of warts, penile cancer, yes.
Okay, thank you very much, Dr. Espinosa and Dr. Alpajaro for that. Do you have any more questions? Pahabol po. So again, it's very important to request for your PSA and to prevent frequent biopsy, we do MRI. So there are different treatments according to Dr. Alpajaro. Enlargement of prostate is not a precursor of cancer. Again, may I call on now our president, Dr. RJ Manso. Sir? Dr. Manso?
Muted, Doc.
Jay, nakamute.
Wait lang, technical challenges. Anyways, thank you, Dr. Alpajaro. So in behalf of the Olongapo City Medical Society, we would like to give this certificate of appreciation. As stated, this certificate is presented to Dr. Sigfred Ian Alpajaro for his valuable contribution to the Olongapo City Medical Society and its cancer awareness advocacy through his lecture entitled Prostate Cancer, Basic Approach to Diagnosis and Treatment, given this 26th of June in the year of our Lord 2021, signed by Dr. Paulo Villarreal, Chair of Prostate Cancer Awareness Month, Dr. Arl Ann Manzo, my Chief of Staff, Assistant Secretary of OCMS, and yours truly as President. Congratulations. Thank you, Dr. Alpajaro. Virtual applause po.
Thank you po.
And likewise, we would like to also give our certificate of appreciation to Dra Maricar Bustamante Mejia for an excellent moderating of this lecture entitled Prostate Cancer, Basic Approach to Diagnosis and Treatment, again signed by Dr. Villarreal, Dr. Arl Manzo, and myself. Thank you, Bing, and congratulations.
Thank you po.
Thank you. Siguro, screenshot muna tayo before we go to the
Yeah.
Carl?
I invite everyone to open their cameras so that you could have great photos for this event po. Thank you again, Doc Ian, for the lecture. Very, very informative. Bago kong alam yung di pala correlated ang size to the no.
Ikaw basta size at
Yeah, I always thought size matters.
The size is rarely a factor.
Okay,
Sorry.
taking a picture, number
It's rarely a
1, 2, 3. Okay, next page. Nasaan mga residents natin? Ba't wala dito? Wow, toxic.
Good.
1, 2, 3. All right, 2 pages. All right, thank you, everyone. Thank you, Doc.
Okay.
Before we end up po, may we call on now our sponsor to give some words. Ma'am Jam Victoria from GEPS.
Opo. Good evening po. Ayan, good afternoon po, doctors. In behalf po of Gets Pharma, I would like to thank the Olongapo City Medical Society officers and its members po. Thank you din po, Dr. Alpajaro, for the extensive lecture on prostate po. Yan. Please let me take this opportunity po to promote one of our products po, our Tamsolin, 400 micrograms for only 37 pesos. Available po at Mercury and We Care Drug po. And habol ko na din po yung brand din po namin ng levofloxacin, Levocin, available in 500 and 750 milligrams, tablet and vials po. Vials po are available po at Bay Point Hospital and James Gordon Hospital po. Again, this is Jam Victoria po. Thank you po.
Thank you, Ma'am Jam.
Thank you po.
Thank you, Ma'am Jam.
Thank you.
Thank you po.
And now for our closing remarks, may we call on now our Vice President of OCMS, Dr. Jerome Michael Acosta.
Good afternoon. Thank you for everyone who stayed. We appreciate your time. We understand that this is a weekend and your time is precious, but we really appreciate the time you're spending with us, with the OCMS. On a personal note, I have to congratulate Dr. Ian Alpajaro, who is a classmate and a friend from med school pa. So congrats, Doc, at magandang lecture. And thank you, Gets Pharma, also for sponsoring this event. Jam is actually one of the kids I grew up with Tita Jude and Tita Anna. So this is it's really my pleasure. And sa uulitin, I will be giving all the closing remarks, I think, for all the CMEs. So always a pleasure, and have a good weekend, everyone.
Thank you,
Doc.
sir.
Happy weekend. Thank you.
Thank you, Boss Ian.
Boss Ian, thank you. The RJ.
Thank you, thank you.
Thank you.
Paki-relay na lang sa akin yung sagot ni Ian, Carla.
Tawagan ko na lang kayong dalawa mamaya.
Teleconsult. No? Teleconsult.
Ano tayo?
Zoom
May
conference.
tayong Zoom meeting mamaya. Tatlo tayo.
Doc RJ, may announcement ka?
meeting pa tayo?
ano na lang. Abangan na lang po yung mga activities for the week. We have an activity on June 21 with
Tuesday.
POGS and PCOM. It's about environmental health. Dr. Delgado will be one of our lecturers, and Dr. Pinky Santos and Dr. Angie Villarreal. And likewise, July 1 at the James L. Gordon Memorial Hospital Grand Rounds, it will be open to OCMS members also. Again, environmental health. And on July 3, next week, Saturday, same time, same channel, we will be having our induction ceremonies. So please attend, everybody. Thank you.
Doc, yung kay ano din, yung kay Doc Arl, sa
Yung
Jerome,
ano,
yan. Yeah.
Yes,
paki-announce naman, Jerome.
June 20, pag-announce ulit ako, boss.
ng lecture ng Chief of Staff.
Yes.
Okay.
Mag-invite ako ulit later and again on Monday before the event.
Thank
Okay
you.
po. Have a great
Okay, see you later. May meeting pa tayo later po.
Pahinga mo.
Wala na? Okay.
Okay, text brigade na lang, bro.
Okay, thank you po. Thank you.
Thank you, everyone.
Thank you. Have a good weekend.
Bye-bye po. Thank you.
Bye-bye.
Thanks, Ian.
Thank you, Boss Ian.
Thank you.